When I see a cricket match, I still see a person supporting Sachin Tendulkar. I ask myself, why is he doing that? I think it's important to remember drugs like serotonin, even in the era of electronib, brigatinib, and lolatinib. So for me, serotonin is still Sachin Tendulkar. This is what we can afford, and I'm taking you backwards into the journey of ALK positive lung cancer. Not that it has been supported by Novartis, but it is what India still needs to continue, for most of its patients. So again, it's just going to be a small deja vu. So we know this. I'm not going into this. ALK positive 7%, BRAF 5.5%. Lung cancer is evolving every day. Now, the most important is to test it by an appropriate technology. I think we all would agree that NGS is the way forward. It helps us to save the tissue. You can look at the SNVs, in deletions, CNVs, and we are getting more and more newer mutations for our existing patients with NGS, which we missed a lot on IHC and other tests. The problem with sequential testing is that you end up eating the pizza and not leaving it for further analysis, where you are using a limited slice of pizza on NGS and getting more information out of the test. Even the guidelines, I think NCCN guidelines clearly suggest a broad-based testing along with PDL1. That is what most of the oncologists are doing in India. In ESMO is still conservative, probably because of the financial constraints, the availability of the drugs in the system. So they are suggesting a sequential, testing. But they do recommend that going ahead and doing a broad-based testing, all the guidelines, including NTRK, including BRAF, including, ALK, they are pretty standard and they should be done in almost all patients. Wherever you have a effective drug to target these mutations, we should go ahead and test these markers, even if the prevalence is less than 0.1%. The benefits of NGS, again, it's reliable. You are able to look at more mutations, especially in deletions. It's accurate, 2 to 3 times more clinically actionable alterations you are getting, and this is what is evident in my practice also. NGS, they provide unknown mutation data, and this is something which was typically missing from a lot of Indian studies when the majority of the testing was through IHC or FISH-based. You do get a data of a nationwide profiling if you are able to generate this data, and there's an acceptable turnaround time. In my practice, it's about 2 to 3 weeks. The challenges are that the setup where the NGS is done, the cost, the technical challenges, how to interpret an NGS. And yesterday, Dr. Patil was also saying that every DNB or DM student should be taught on how to interpret NGS, irrespective of whether they will be reporting it or not. Accessibility, false positive, and turnaround time. So to solve one of the existing problems in clinical practice, and all the private clinicians would agree, this is one magical coupon which Novartis has provided. This looks at a 12-gene DNA-based and 4-gene RNA fusion-based panel, along with a complementary PDL1 testing through SP142 or SP263. Pretty standard. The turnaround time for PDL1 is 2 weeks. The turnaround time for mutation testing is 3 weeks. So by the time the patient goes on to a next chemotherapy, or if there's enough time to wait, we do get the results pretty fast. The test cost is 8,500, supported by 2-3 laboratories. Core is one of them. This has really, shaped and changed my practice. So let's look at why Sachin Tendulkar is Sachin Tendulkar. This is ASCENT-4 data where, it was a serotonin versus PEMSIS in previously ALK positive, naive, metastatic NSCLC. There was clear-cut separation of the curves with doubling of the median PFS, overall response rates up to 72%, duration of responses to 24 months, of the tune of 24 months, and 24 months overall survival of 70.6. So second generation TKI leading to a substantially good benefit. ASCENT-4 in Indian patients, it even did better. There was 34% reduction in the risk of death. Then came ASCENT-8, serotonin 450 dosage with a low-fat meal, proved to be equally efficacious with all the parameters of PK studies and other studies, and it showed that even the 450 was better in terms of PFS and OS, and this is what is now the standard of care, that 450 on a fed diet is better than 715 when we look at the side effects. This is very, very standard of information where people know that brain metastasis is the most common complication in ALK positive as the journey persists. Serotinib has brain penetration, so there is a reduction in brain metastasis going forward with serotinib. And patients who present with even de novo brain metastasis, which are asymptomatic, there is the definite benefit in terms of better than chemotherapy with serotinib arm. Patients who do not have brain metastasis tend to do much better in terms of overall survival. Again, some fact which is already known to most of the oncologists. So there is a definite intracranial response with serotinib of the tune of delta of 45%. This itself is good enough for us to suggest this therapy in spite of having multiple options in the first line therapy when we look at when it competes with the third generation. So it does give you a good PFS. It does give you a good survival benefit. These are again multiple trials, and there has been an overall survival benefit of serotinib in Profile 1014 and Ascent trials. Safety profile, we've used this drug. We are quite comfortable. Nothing much. Quality of life significantly improved. Side effects, typical side effects of any TKI, of diarrhea, nausea, vomiting, but nothing as much as what we are used to with chemotherapy. So for me, lorlatinib, maybe a Surya Kumar Yadav, crizotinib, again, lower order batsman, but serotinib is, in the second line, which we can afford, is one of the standard of choice that, drug of choice that we still need till these third generation molecules, they become more affordable to the pocket. Even NCCN still allows us to have serotinib as one of the first line options in ALK positive first line therapy. This again is one graph which I would like to end my talk with. When we look at this very simplistically, if you start lorlatinib upfront, what do you offer such patients once they are progressed? Giving them serotinib gives them an option of using alectinib in the second line and lorlatinib in the third line. So I do counsel my patients that let's choose a regimen wisely where you would save money today and you will have an answer tomorrow, and let's wait for alectinib or lorlatinib to become cheaper to go safely on the second and third line. Yes, it has a superior efficacy, then chemotherapy, and then the first line. Brain metastasis is helped. For me, this is still Sachin Tendulkar. Let's look for what we can afford as a country. Thank you so much.